Good morning, everyone. Thank you all for joining us today for another APSAD Insight webinar. My name's Tracy and I'm one of the nurse educators here today at Insight. Today we have one of my brilliant colleagues, Rebecca Mounsey, joining us fresh from her successful presentation at the APSAD conference last week. Beck is a very experienced clinician who's worked in varied roles across the AOG sector and is now the senior social worker here at Dovetail. She's got a special interest in nicotine dependence in young people, and today we're very lucky to have her here to discuss the barriers around delivering effective smoking cessation treatment to young people. So I'm going to hand it over to Beck now.
So as Tracy said, I'm going to be delivering a seminar today on barriers to managing tobacco dependence in young people under 18 in Queensland. So this will be me sharing the results of a qualitative research project we conducted in 2020 on this topic of understanding the barriers to managing tobacco dependence in young people under 18 in Queensland, so school-age young people. But before I get started, I would like to acknowledge the traditional owners of the land on which I'm on here today, the land of the Yagara and Turrbal people, and pay respect to elders past and present. But just firstly, for those of you who don't know, at Dovetail, we provide clinical advice and professional support to workers, services and communities across Queensland who work with young people who use alcohol and other drugs. So this includes things like full-day workshops or shorter training sessions on drug-specific topics. We also provide case support to workers over the phone or via email. We might help services with policies and procedures, things like that, or providing resources for workers. So sometimes this is other people's resources or resources that we create ourselves here at Dovetail and Insight. And at Dovetail, so we are the youth-focused arm of Insight. And so Insight probably don't really need an introduction in this setting. But you can, just a bit of a plug for our blog here, you can visit our website and scroll down the bottom, or you can use the QR code on this page to subscribe to our weekly digest email. So every Friday at 10 o'clock, we send out an email and it's got four either articles, research projects, links to webinars, podcasts, or things like that that are related to young people and drugs or mental health issues or wellbeing, other things like that that are relevant. It's a great source of professional development opportunities. So please subscribe if you are interested. And just a little bit of a plug for some of our resources here. So this is a screenshot of our resources tab on our website. We've just recently put up an e-cigarettes and vaping's little toolbox. If you're interested, it's a very topical topic at the moment. Check it out. We plan to add things to this as we go. So, but yeah, have a look if you get time. But onto the project team now for today's talk. So you can see on the screen here that the project team was made up of workers from both Dovetail and Insight. So there was myself, Dr. Hoyang Karen Lee, who's joining us online today, and my team leader here at Dovetail, Cameron Francis. So although I'll be presenting today, this project was a team effort. So in the last 2 decades, the prevalence of smoking in Australia has been decreasing. And so we know from 2001 to 2019, the proportion of 14 to 19-year-olds daily smoking fell significantly. As we can see here, the first lot of bars in this graph from the National Drug Household Survey, we can see the decline in daily smoking. However, we know that these figures can be disproportionate and that those living in remote or very remote areas are twice as likely to smoke daily than those living in major cities. And similarly, those in low socioeconomic areas, they're 4 times more likely to smoke than those living in the highest socioeconomic areas. And we also know from the stats that young people with mental health diagnoses are more likely to smoke at 36% compared to those without a mental health diagnosis at 14%. So although the daily prevalence of smoking is decreasing, it is still a major risk factor that contributes to the widening gap of health and social and economic inequalities for certain population groups. It's also still the leading preventable cause of disease and death in Australia due to the lag between smoking and the onset of illness. And so we know from the evidence too that many adults start smoking in their adolescent or teenage years, and that young people who smoke become dependent on nicotine faster than adults and at lower, more intermittent levels of nicotine use. And so far, the public health approaches to preventing tobacco use in young people includes things like bans on advertising, prohibiting retail tobacco sales to children, increases in tobacco tax, and also things like school smoking policies. And so we do know that these campaigns against smoking have been successful this far. The second graph, so talking about our campaigns against smoking being successful. So this data that we're looking at now is from the Australian Secondary Schools survey asking about smoking in the previous 4 weeks. Unfortunately, it only goes to 2017 at this point because COVID interrupted the 2020 data collection. But still, you can see here quite clearly the steady decline in smoking. So the orange line there is to 12 to 15-year-olds and the blue line is 16 to 17-year-olds. And if we overlay here the timeline for major government initiatives like price increases and the introduction of plain packaging, we can see the ongoing impact these initiatives have had in helping to reduce smoking rates in young people. However, anecdotally, we feel we may have come as far as we can with some of these strategies. And anecdotally, we have heard of adverse effects in response to some initiatives such as price increases. And so I'm going to go into that a little bit more in the next slides now. So Dovetail staff noticed an increase in calls relating to smoking. So workers were calling to seek support regarding school-age young people who were dependent on cigarettes and were experiencing a range of harms, so not just health-related harms. And so I'm going to give some examples of these now, what these calls were. But I'll just point out that this may not be representative of the whole state. This is just anecdotal information from the workers who called us that led to the inception of this project. So workers told us that young people were experiencing what we've called here acquisition-related harms. So this was things like young people being taken advantage of when trying to obtain cigarettes. So examples of this is like hitting up older strangers for smokes and being exploited or taken advantage of in some way during this process. Or they also might resort to smoking used butts from the ground or sourcing illegal tobacco called chop chop. And this was related to price, or we were told was related to price, or also engaging in crime to get cigarettes, or trading things like sexual favours to get cigarettes. And again, these were, price related because cigarettes are becoming so expensive. And then we were also hearing about harms to school engagement. And so some examples of the calls we got here were from some workers working with Aboriginal and Torres Strait Islander young people who were moving from more remote areas to bigger cities to complete their high schooling, but finding that the city schools had stricter no smoking school policies, and workers were really struggling to help these young people who are experiencing withdrawal symptoms, during that 6-hour day at school, having irritability, cravings and stuff like that. And so consequently that, they would take off to go and have a smoke and end up getting expelled and sent back to their community where they were unable to complete their education. Another example was from a flexi school where the worker was talking about young people who were smoking off-site across the road from the school at a bus stop, but there were complaints from people in the community about this. And so the young people were forced to move to a different area that was a bit more hidden. And the worker was talking about how this, the young people being in a more discreet location was leading to more antisocial behaviours. So more young people getting into fights and more young people starting to then also smoke cannabis and then not making their way to school. And lastly here, also calls about conflicts and breakdown in living environments. So this was things like calls from workers who worked in out-of-home care that would talk about young people experiencing irritability or behavioural issues in the home because they were in withdrawal. And this would frequently then result in them absconding from their placements in order to go and try and source cigarettes. And this was having impacts on their placements because of the behaviours and the absconding, but workers also talked about young people experiencing harms, again, through the practices of acquiring cigarettes. So going about hitting up older people, possibly strangers, being taken advantage of, having money stolen off them and things like that. So workers were feeling a bit stuck in this area, and we were really interested in understanding if workers across the state, other workers across the state, were also having these issues, and if they were the same in different role settings and different contexts. So that's how this project started, and our main research question was, what are the difficulties in managing and supporting these young people who are under 18 with nicotine dependence? And so we used the snowball method to recruit participants via our Dovetail weekly newsletter, which I just promoted earlier. We conducted 12 semi-structured interviews in 2020 over the phone. They all took about 30 to 60 minutes each. We recorded and transcribed them, and then we analysed the data using a grounded theory approach. Our participants were from different professional backgrounds and roles and different work settings. So we had people that worked in the community in different settings and also in schools and things. And then we also had workers that worked in an inpatient setting. Our workers had different levels of tobacco treatment experience. So this varied from kind of no specific tobacco treatment experience to qualified tobacco treatment specialist. Our workers came from a range of major cities to more rural, regional and remote areas across Queensland. And some of our workers identified as working specifically with Aboriginal and Torres Strait Islander young people. So now to our findings. So what we found here was that we were able to broadly categorise our findings into two areas of what we're going to refer to as resources. So the first is resources, so accessible to young people. So the internal resources are things like skills and abilities of young people. So this is like coping skills, impulse control, things like that. And then also beliefs. So beliefs maybe around things like believing change is possible. And then the other category was external resources. And so this was things external to the young person in their environment. And we had a lot of data here. And so we've created a few, these are bigger subcategories here. So the first one is social resources. And so this refers to supportive people in a young person's life. So family members, community members, peers, things like that. Material resources refers to things, practical things like money, transport, phones. And service resources refers to services and systems that are accessible and appropriate to young people. And so what we found was that research on resilience says that when external resources are available to the young person in culturally meaningful ways, combined with adequate support to support those internal resources, that this supports the young person's capacity for resilience and reduces their vulnerability to negative outcomes. And so we interpreted our data to find that a lack of sufficient support and appropriate access to these resources really interacted and created barriers for workers that were trying to support these young dependent smokers. So I'm now going to explore each of these areas in a bit more detail and share some quotes directly from the workers that we spoke to, but I'm going to focus more on the service resource section because this is where we found most of what we thought was the most interesting data. So highlights from the internal resources category were that workers reported that young people were using smoking as a coping mechanism for things like stress, depression, anxiety, and regulating their emotions. With beliefs, workers made reference to young people not really seeing tobacco as a drug or a bad drug. And this might be because they're not experiencing negative consequences in the here and now. So this was things like hangovers or having an unpleasant high or legal consequences. And workers said that young people just weren't concerned by the long-term health harms from smoking, kind of seeing themselves as bulletproof, or maybe that, they would quit eventually before that happened to them. So consequently, giving up smoking isn't very high on their list of priorities, or their motivation to stop was quite fluctuating. And sometimes workers said that young people didn't even believe that they actually had a real addiction, and they didn't really understand withdrawal, the symptoms of withdrawal, or when they were going into withdrawal. And so all of these impacted on the young people. Another harm that came out of this that workers mentioned was that young people's smoking can then affect their decisions that they make about other treatments. So there were some examples given where young people refused entry into, they refused to go into residential rehabilitation for other AOD use, because they weren't going to be able to smoke in those facilities, or they self-discharged from hospital settings because they weren't able to smoke and they felt that smoking was really the only way that they could cope. So they would be self-discharging. So now just read some quotes from the workers from this internal resources section. They don't see the smokes as an issue. They might see the cannabis as an issue because it's illegal and they don't want to get in trouble with the cops, but they think, I'll just stick with the smokes. Some of them really do use it as a stress reliever and to calm themselves, and they'll report that they're actually smoking from stress. And the motivation ebbs and flows. Like at times it's a high priority and other times I need a cigarette because I'm stressed. So now the findings here from the external resources section, and these were really around family and carers. And so there was, so this is the social resources, sorry. There was reference to impact from peers or living in environments where there was high smoking prevalence. But really most of the information here came out about, the impact of young people's families on their smoking. And so workers said to us that it could be really difficult to collaborate with families, especially when those families were experiencing their own complex psychosocial issues. And so we had many references to families experiencing poverty, their own AOD issues, family conflict, or being from marginalised backgrounds. And workers also said that when young people lived with carers or family that smoked, that it was really hard for them to quit, even if they did have some motivation to do that, because they're just surrounded by so many triggers, and that young people often have limited access over this and where they live. And this was also then compounded when the workers spoke about not having scope to work with the family and support them as well. And so I'll just read a couple of quotes here. So our low socioeconomic families, like their kid wants to quit smoking and that's good, but they're just trying to pay their rent and get food on the table and get their car fixed or get to appointments themselves. They've got so many other things happening. And this one, I can talk to the student and give the student education, but then they're going back into a home environment with the parents who haven't received any of that education. I've had a student and I gave him education and he came back a couple of weeks later and said he wanted to quit. And so we've gone down the whole path of calling Quitline and getting nicotine replacement therapy for him. However, both his parents smoke inside the house. He's got the smoke constantly around him. And so, we know from our experience with adults or anyone trying to abstain from smoking or any drug for that matter, that we often need to avoid triggers and, avoid things like going out or things that we associate with smoking. But young people often don't have autonomy over this. And this is a really good example of this, where being in a space, their home, that they can't avoid really, provides constant triggers for it, making it really hard for them to make that decision to quit and then to stick to it, especially if their motivation is a bit fluctuating, like some of the workers suggested that it is. So now I will move on to the external resources, and we'll look at the material external resources. So this was really about lack of practical things. So young people having lack of access to basic needs like money for services or pharmaceuticals, or even like nicotine replacement therapy, or money to buy phone credit, return worker phone calls, or lack of access to transport or money to get transport to make appointments. And some quotes from this section. So that can be a bit tricky, getting a hold of them. So even if it's a phone consult, they've either missed the call or they don't have credit to return the call. And it's a problem helping kids because of their age. They're not adults and they don't necessarily have parent support. So it's always a deal breaker. They can't physically take themselves anywhere. They can't pay for any services or pay for pharmaceuticals. So now on to our findings from the external service resources. So this was a little bit tricky. There was a lot of data in this area, but overall we broke it down and we were able to sort of put it, theme it into areas that we understood as being that current service systems often don't meet young people's needs. And so I'll give some examples of what workers spoke about with this. So they were talking about systems and services not really allowing time to build rapport with the young person. And workers told us like how important that they felt that was to get that rapport there and the trust with the young person so that they would be able to talk about their smoking or the reasons why they're smoking. But just finding that they don't have time for this, it's not part of their system. And this was also covered things like hours of service operation and flexibility and actually being able to access young people. And some workers spoke about the interventions with young people being really opportunistic. And one worker said to us, you have to be there at the right time when they're willing and able, and sometimes our systems just don't allow for that. Also, workers spoke about when multiple services are involved, there can be conflicting priorities and service agendas. And a health worker was speaking to us about, sometimes in circumstances where they're really concerned about a young person smoking and want to work on this, but there's other services involved that maybe this is not a priority or something that they would work on in their service. And the workers talking about feeling like sometimes it impacted their practice when they felt like it was a bit undermined maybe by other workers or not supported wholly by other workers. And also some workers spoke about feeling undertrained in this area and having no set responses or things like no routine screening in their workplace for smoking. They talked about missing opportunities because people who might be able to provide support aren't asking young people routinely the question, do you smoke? And then lastly here that workers spoke about existing treatments, so things that we already have in place for smoking, so existing behavioural interventions, but also existing like nicotine replacement therapy-based interventions that are often not really always in practice accessible, suitable or appropriate for young people. And so this is the part that we're going to dive into a bit deeper now. So firstly, we'll talk about the behavioural interventions. So we found from what workers said that it seemed to be the adult-centric nature of some of these existing behavioural interventions that meant they just weren't really appropriate for these school-aged young people. So we were told that print resources like brochures or assessment tools and intervention tools are not appropriate. They sometimes don't meet young people's literacy levels, or sometimes they're not really developmentally or age appropriate. And so an example of this is workers spoke about brochures and things or interventions that use money as a motivator really might not be appropriate for those young people where maybe their family are providing them with cigarettes or they're collecting used butts. Or another worker talked about how the nicotine dependence assessment tool that they used wasn't really accurate for use with young people. The questions weren't necessarily relevant and it didn't reflect accurately what dependence might look like in young people who typically don't need as much nicotine or as frequent use as adults to be dependent. And in some cases, the barriers that workers spoke to us about were specific to this setting or the environmental context or cultural context. And so I'll give an example of what I mean by this. So we spoke to workers, some of the workers were from school settings, and they talked about behavioural interventions that were linked to punitive responses, so being caught smoking at school, that they found that detrimental and it was hard for them to build rapport with the young people when they were sent to them for an intervention as part of a punishment. But then one worker that worked in a school but in a more rural remote sort of area where it was quite a smoking saturated area, found that they wished in that area that their school did enact some sort of punishment for smoking, because what they found was the school wanted to keep the young people involved, which was great, so they weren't enacting punishment, but then the worker found that there was they had no leverage or nothing to use as a motivator to help prompt change in the young person, or motivate change, sorry, rather. And so this led us, it just made us think about how the environmental context matters, and that a standard one-size-fits-all approach to this probably won't work in some communities. And lastly here, we were also told that some interventions and traditional quit smoking services, although really good, are often cessation-based and therefore not often always appropriate or relevant for many of the young people who are just not yet ready to quit. And so some of the workers said to us, in every other area of alcohol and drugs, there's harm minimisation. Continue to use, but more safely. With tobacco smoking, it's all stop. And the stuff we get tends to be very generic across the age span. The big smoking brochure, I don't give that out because they just look at you and go, what? I don't feel we have enough material to really be able to get some information across in a very age-appropriate way. So now on to NRT as a treatment or intervention. And a lot of the barriers that we came up with in this area, really, it actually centred around access. So lack of access for the worker or the young people. And so workers that were out in the community, they found that it could be really hard to support the young person to access and use NRT to manage withdrawals, particularly in certain settings. So an example of this was some school-based staff talked about, they had identified that NRT might be helpful to help a young person get through the school day when they're identified as dependent. And avoid suspension and expulsion and help them manage those cravings. But the staff were unable to provide the NRT themselves, and they felt that if they did have access to, say, gum or lozenges, and if they were able to, distribute that to the young people, it might help them in the here and now to not leave school and smoke and not get suspended or expelled. But that, they just weren't allowed to do that. It wasn't part of their role, or it's also a drug. NRT is classified as a drug, so something they couldn't give out. But just in general, workers we spoke to that worked in that community setting who didn't have their own access to NRT really wanted it. They wanted to be able to distribute samples and explore NRT product options and really make the most of those opportune moments as they arose where motivation to make a change might be high. So some workers commented that when they had to use external providers, like when a referral was made elsewhere, or maybe they made a plan with the young person to see their GP, that it was just a bit of a barrier, that the young people often wouldn't follow through with that. But if they did, and by the time the NRT arrived, the young person's motivation to change it could be gone. And they felt that the young people often needed a bit more support to actually use and continue using the NRT. And so one of the workers said to us, no one's there when it arrives in the mail. Who's going to say, this is how you use it? Hey, open the box. Come on, stick one in your mouth right now. And they can't get the NRT. Like, that's usually the issue. If you've got someone who's young and they don't have money, how are they going to get it? And is it going to be served to them? So if you're 16 and you go down to the chemist, are they going to sell it to you over the counter, or are they going to say you need to have an adult with you? And it's getting the educational partners to understand that it's really addictive. We need to have some sort of management plan to assist with their addiction and helping them limit the symptoms of withdrawal or behaviour that comes with that. Allowing them to have breaks, allowing them to have nicotine replacement therapy gum, but gum is banned in a lot of school settings. So now on to the nicotine replacement therapy barriers for workers that were working in an inpatient setting. So these workers said to us that they found that NRT could be really helpful to reduce withdrawal symptoms and behavioural issues on the ward, but they did express that they could experience issues actually obtaining a prescription. And this was mostly based around fears of young people misusing the products, so fears that they might hoard the products and then take them all in one go later. And another barrier here was about having access to a range of NRT product types. So having access to lozenges, gum, patches, inhalators, all in different strengths, and allowing them to be able to explore this with the young person, find the right dose and the product that the young person likes. And one worker mentioned how young people often like the inhalators, but they're usually not allowed them because it's, again, linked to fears that they'll misuse these products. So self-harm with the products themselves or hide other drugs and things in the inhalators. And workers in the inpatient setting also told us it could be difficult to support the continued use of NRT post-discharge. And this was for various reasons, including, it being difficult to get other external workers to help facilitate this process because they don't see the benefit in it or they're not able to do that. Sometimes this was attributed to not being able to get guardian consent for the young person when they're under the care of the state. And so some quotes for this section here. People are really fearful about being able to prescribe nicotine replacement therapy because they're under 18. It's actually easier for them to access butts and cigarettes. And it's not that it's contraindicated, but it says caution under 12, and that can be a barrier. They go, oh, can't use it in kids under 12, and so then they're not proceeding any further. And I've seen a number of young people who are unable to access NRT because they come under the care of the state. And nobody knows who can go and buy the nicotine replacement therapy and how they continue to use it as well. So that's been really difficult. And you don't have the same treatments options. And this was in comparison to adults. And that's probably where it falls down. So you don't have differences with the patches. You don't have the different strength of NRT. You can't give them a whole stack of it to self-medicate. So now onto the barriers related to the NRT products themselves. So some of these barriers were related to the products themselves not being suitable for young people. So this included immediate adverse reactions to patches on young sensitive skin, the sprays containing alcohol, so therefore they're not always suitable for young people under the age of 18. And then it's not NRT, but other pharmaceutical products, they're contraindicated for those under 18. And young people just not liking the products themselves, or they're not youth friendly. And so workers talked about young people struggling to use them as required to be effective. So this was things like forgetting to put patches on or struggling to use the gum in the correct chew park method. And so some quotes from this section were, even if they say, oh yeah, I could use that, then next week when I say to them, okay, have you worn your patches this week? And it's like, oh yeah, but I just keep forgetting. And this quote, I put a patch on him just to see how he would go, and he instantly came out in a rash. So just being a really young person, his skin was still quite sensitive, and so patches were out of the scenario because of that reaction. And then that makes it really difficult because he didn't feel he would be able to access and use the nicotine gum in the right way as well. And my other strategies are giving samples of the nicotine therapy when I've got them, rather than just going, go out and get some, because I'm making sure that they know what to do with it, what it tastes like, and how to use it properly. And that's when I'll discover that they hate everything. And so as we can see from what I've presented so far, that there was a range of barriers for workers working with school-age young people who are dependent on cigarettes. And I think, you know, this last point on the NRT was really interesting. It was one of those things that the workers that didn't have access to NRT really wanted it and really felt it would be helpful. But then those workers that did have access to NRT and were able to use it were also facing barriers, you know, around the products themselves and the motivation of the young person. But so, look, the first part of this, the title of this project was, but it's the least of their problems. And this is because this is a message that we so often hear. And, you know, I'm not sure why this is. I think it could be about, you know, when we think about the harms of smoking, we think about the health harms quite often. And those health harms take many years to come out. And, but I would argue, and from what we've talked about in this talk today, that school-age young people are experiencing harms from smoking, but they're often overlooked and things that people don't recognise. And so this is that anecdotal stuff that I talked about at the start of this presentation, like where workers told us, young people were becoming disengaged from school because of their smoking. And we know that when young people are disengaged from school, that this is really detrimental to their trajectory. And that they can become more vulnerable to increased AOD use, poorer mental health, engagement in the criminal justice system, all of those things. We know that they can refuse treatment for other things because they can't smoke. Workers told us that it affects their housing and can cause breakdown in those living environments. And then also that they can experience those acquisition-related harms related to price increases or being taken advantage of or exploited when they're actually trying to get their hands on cigarettes. And so this is why we thought this research was really important, because we think young people are experiencing harms in the here and now from smoking, but there are barriers. Workers are finding barriers to supporting this. And so overall, how we've summarised this is that we found that there was a lack of helpful and meaningful both internal and external resources of young people, and that these internal and external resources kind of interact, and then that creates barriers for workers addressing tobacco dependence in school-age young people. And we found that these barriers looked different depending on the worker setting or the environmental or cultural context. Within all of this, we really specifically identified that existing tobacco treatments and interventions that we have access to today, most of them are kind of contributing to these barriers. As workers told us that they were adult-centric and mostly cessation-based, and therefore just not really hitting the mark or appropriate for use with under 18s who are just frequently, pre-contemplative. They're not yet ready to quit. And then we found from this project, then that there is a need for under 18 specific treatment and intervention, including tobacco harm reduction options, an intervention that supports minimising both health harms and the non-health harms that young people are experiencing and that I just mentioned. But also any of these treatments and interventions really need to be developmentally and age appropriate and appropriate to the young person's stage of change, and be suitable for use in the institutional settings that they exist, like within schools. And interventions should also consider worker context, wider cultural and environmental contexts, just so they're relevant. And so this speaks to what I spoke about, where a one-size-fits-all approach probably won't work everywhere for this. So before we finish up and get to the questions, I just want to share a couple of limitations of this study. So some key youth sectors were not represented in this study, while others were potentially overrepresented. We were hoping we'd get a widespread, but we used a snowball recruitment method. So it was really about people who were interested, who then shared that with other people, and participants came to us. So we didn't get an even spread over the youth sector. And that also, by naming our study managing the barriers to nicotine dependence, we may have potentially caused a bit of a selection bias and only targeted those workers who were actually experiencing barriers. And a note on future research. So given the increase in young people using e-cigarettes in 2021, we recognise that future research may need to include nicotine-containing e-cigarettes. And also, it's really important to note that we need to hear the voice of young people on this topic. We started with interviewing workers because this is our cohort. We work with workers, but we would love to hear from young people in future and find out what they think about this and what they think might work for them. Now, lastly, before we go to questions, I just want to give a really big shout out and thank you to the 12 clinicians who took the time out of their really busy schedules to participate in this study. We had hundreds of pages of really great data, and it was all really great stuff. I hope some of them have tuned in today and are listening to this. And I hope that this helps to highlight for everyone why this is a tricky space for workers. And I hope from this and delivering this, the findings of this research, we can get some conversations started and get people thinking about what are some potential solutions we can come up to for these barriers, or where could we maybe do some more research to help with this. So now we will go to questions. Thank you for listening.
Thanks, Beck. I reckon you're really going to be starting some conversations out of that. It was really interesting. I do have some questions for you. Someone asked that, you mentioned that there's a bit of a caution for using NRT under the age of 12. What does that caution relate to?
I think that Karen, so Dr. Hoyan Karen Lee is online. She might have something to add to this. It's on one of the clinical pathways that workers use, and it says caution for use under 12. My belief is that it's not contraindicated, so it means that they can use it, but they just need to monitor it. Is that right, Karen?
Hey, Beck. So on the product disclosure statements for the patches, for instance, anyone aged between 12 to 18 just needs more monitoring, because there's more data on adults, obviously, for NRT. The studies that are published, including the meta-analyses for young people in this age group, mainly are inconclusive because they are obviously also based on cessation rather than harm minimization that we're trying to keep, kids in schools or health services. Hope that helps.
Yep.
Thank you for jumping in there, Karen.
And just sort of as an adjunct into that one, is it actually permitted to be prescribing kids 12 to 16 NRT?
Yes.
Yeah.
Karen, do you want to add to that?
Absolutely, yes. Of course, with any kid, there's more variability. So you just got to check in with them. Like some of the participants in our study talked about the easiness of the youth skin to have rashes, or even the mouth spray, as the NRT has alcohol in it. So obviously you've got to weigh up pros and cons of any approach there.
Was there any sort of, was it mentioned any sort of benefits from using the flavoured lozenges and, some of those berry flavours and things like that, whether they were better accepted?
That didn't specifically come up, but workers in the settings that had access talked about wanting to have a range of products, because wanting to meet the young people's needs, finding, having easy access so they can try them and hopefully find something that they like. Yeah, cool.
Did vaping come up at all?
Vaping did not. Sorry, I lie. It came up only once. And this was really because, these interviews were conducted in 2020, and that was before vaping really hit us here in Queensland, or, certainly from what we know here at Dovetail. The calls for us around vaping came in when school went back at the start of 2021. That's when our phones started ringing and people were asking about vaping. I don't know, they must have all started doing it on the school holidays prior to that. But one worker talked about a 14-year-old boy who wanted to quit smoking and wanted to do that using a vape. And the worker was trying to find information on the efficacy of vaping as a smoking cessation aid, specifically around young people, and was really struggling to find that at the time, or any information on vaping. And so that's what she mentioned, but that was it. It was just the one mention of vaping.
Cool.
And that could probably tell you that we've had many calls since.
Many calls since, yeah.
It's taking off, isn't it? Were there any specific barriers in the Aboriginal Torres Strait Islander populations?
Some of the specific barriers in that population group really centred around, I think, the normalisation of smoking in some of those communities where there was really high prevalence. So, young persons, their whole family might smoke. And so it's a really smoking saturated environment. So it was very difficult for those workers to work with those young people, and they didn't see any negative consequences. And also in some of those communities, the workers spoke about the generations of smokers, and maybe sometimes having poorer health literacy. And then, you know, the obvious things sort of sometimes that remote workers experience around lack of access to other services and resources and things like that.
Cool. Do we know why young people become more dependent on nicotine or become dependent faster than adults maybe?
Yeah, I'm not an expert in this area. I believe young people become addicted faster with less nicotine than adults. It's to do with the reward pathway and their increased sensitivity to experiencing reward from smoking. So they feel that at a heightened level and maybe experience the negative side effects from withdrawal to a lesser extent. I think there's also some research about young people being more susceptible to smoking cues, like visual cues. And so that combined with then them having that heightened sense of reward and then sometimes less capacity for craving or urge regulation, that puts them at more risk. Did you want to add anything else to that, Karen?
Thanks, Beck. No, I think you're pretty comprehensive. The only thing I'd also probably mention is that the amount of time between smokes, young people might not consider that a dependence. For example, it could be a weekend thing for young people. But certainly with the vapes that we're getting the calls about, the pattern's a little bit more frequent, isn't it?
Yep.
Oh, so what's next? Where do we go from here?
That's a really good question. I think, like with anything, more research. We need more research specifically into young people. I think, you know, what this study pointed out was that we're trying to apply strategies that we apply with adults, and it's not necessary, it's not working, or from what we've been told, it's not working. And so it would be really great to have some more research on what works for young people and what do they want to see happen in this space, and try and help them in a way that is helpful for them with products and things that they want to use. So yeah, I don't know the answer, but more research and specifically around young people and applying those principles and stuff that we already know about young people. You know, some of the stuff that came out that I spoke about at the start about young people specifically, you know, not being motivated by long-term health harms. Like, we know that that's not new. We already knew that about young people. So applying that to interventions that we do and trying to find something that actually works for young people.
Is our current method of sort of trying to prevent the uptake, is that working? Are we seeing the drops in numbers taking it up? Yeah,
like the smoking prevalence rates have been dropping, like the major government initiatives that we've been doing has been dropping. So that's been really effective. But then it's now helping those people that are smoking that then go on to become the adult smokers.
Yep.